everyone. My name is Janine Bennett and I'm the Assistant Secretary of Digital Business and Sector Engagement at the Department of Health, Disability and Ageing. Today, I'm very pleased to be speaking with Professor John Hirdes, a leading voice in the global conversation on ageing, health systems, and the transformative role played by data in care delivery. A self-described freak of nurture, Professor Hirdes brings a unique blend of curiosity, compassion, and scientific rigour to his work. He's a faculty member at the University of Waterloo's School of Public Health Sciences and has authored over 350 articles in peer-reviewed journals and academic literature. His leadership in the Inter-Eye Consortium has helped implement standardised assessment tools that have improved care for people across Canada and around the world. In 2023, he was appointed a member of the Order of Canada in recognition of his pioneering contributions to health screening and quality of life assessments for older adults. Welcome, John. Thank you so much for joining us from Canada today.
Great. Thank you for having me.
Pleasure. Your presence here today couldn't be more timely for us. Here in Australia, we're witnessing firsthand the role of data and digital in shaping the future of aged care and healthcare more broadly. We're introducing measures that include enhanced rights and protections for older people, stronger rules and regulations for providers, higher quality care, easier access and entry to services, as well as greater choice and transparency and a stronger workforce in the aged care sector. All of these things are enablers for a better aged care system, but they're also enabled and modernised by our digital infrastructure. So we're very much looking forward to hearing your insights, both from your own work and also from the Canadian perspective, and to learn how data and digital can continue to drive really meaningful change in aged care and healthcare more broadly. I understand you've prepared a short presentation for our audience, so I'll give you the floor and let you go. Thanks, John.
Well, thank you again for having me. It was a pleasure to be in Australia recently and to make connections with folks like you and your team. We have a lot of common areas of interest, so I'm delighted to have this opportunity to explore this a bit further today. So what I'd like to do is to, first of all, talk about why Australia and Canada should be natural partners collaborating and trying to understand how to manage some of the challenges dealing with population aging and the needs of persons with disabilities and other complex populations. I think there's a lot of affinities between our two countries that give us an opportunity to work together in a very productive way. I'll then move on to talk about data standards and artificial intelligence that's emerging in the healthcare system. And I'll talk a bit about the use of inter-eye systems in Canada. And I'll give you one example of how we've used big data and advanced analytics to refine the way the Canadian healthcare system works. So if we think about our two countries, we're comparable in many different ways. So if you look at life expectancy, Australia has a little bit longer male and female life expectancy than Canada does, but basically the same kind of breakdown. If we were to look at the populations we serve, Canada has a population of around 40 million individuals, Australia 27 million individuals. About 80% of Canadians live in urban settings. There's more folks that live in urban settings in Australia. We have about 1.8 million Indigenous individuals compared to 0.8 million Indigenous individuals in Australia. We have a similar population age structure at around 19% in Canada, 17% in Australia. Both are countries with very large land masses and sparsely populated areas. The population density is just a little bit greater in Canada, but really we have very large countries with people concentrated in a few urban areas. In terms of wealth, the GDP per capita is a bit higher in Australia. And the one thing that's different, you have a lot more dangerous animals. All your animals want to kill you. You just have to worry about polar bears and maybe grizzly bears in Canada. So there's an awful lot of affinities between the two countries that make us very comparable. I want to take you back to when I was a graduate student. My PhD supervisor was Dr. Bill Forbes. He was the founding president of the Canadian Association on Gerontology. He had two PhDs. One of them was in statistics, and he was the country's leading researcher on long-term care for the elderly in 1986. And so he wrote this book on the future of institutionalization of the elderly in Canada. And he noted a few things. He said there was no national data beyond age and sex for long-term care. And he said we really should have a standardized assessment system in place. But he was worried in 1986 because he said, well, you'll have to have computers to do that. And nobody could imagine computers coming into long-term care. Of course, that's a very different world from where we are today. But the lack of having standardized data available meant that there was also a very limited conceptualization of quality measurement. Really, what he talked about was survey-based research methods to look at resident experience, but not really clinical measures of the quality of care being provided. He was also very worried about how good the evidence was for placing people into long-term care homes from the community. And he worried that if we didn't do things to improve the quality of long-term care or nursing homes, then they would really be considered the iron lungs of gerontology, was a phrase that he coined to describe that. And so in that 150-page book by Canada's leading quantitative researcher on care of the elderly in 1986, this is the only data table he had in there. One table with a description of ADL impairment on about 900 individuals in one region of one province that came from a study. That was it. He had no more data than that to work with. But he had a sign on his door. He loved gathering data sets from Statistics Canada, and the sign on his door said, data, data everywhere, but not a thought to think. That quote came from the guy who came up with the term counterculture. And what was behind it is that you can't just use data to transform a system like a healthcare system. But really what he was arguing is you have to have big ideas that you can then test using sound analytic methods to drive change. So data on their own aren't enough. You have to have solid ideas, policy ideas that you want to test out, and a solid analytic framework for how you test those data. So that brings us to INTRI that I became involved in the mid-1990s. INTRI is a not-for-profit charitable network of over 150 researchers and clinicians and policy experts from around the world. We've been doing this type of research for over 30 years, and what we do is to develop comprehensive assessment and screening tools to look at the strengths and preferences and needs of vulnerable populations of all ages. We're interested in people with complex needs rather than people with fairly simple, straightforward health needs. We do this through a multinational collaborative program of research where we create these new instruments and test them out. And we're really interested in how do you take data and transform it into evidence that can inform decision-making at all levels of the healthcare system. And we're particularly interested in supporting collaborative communities of practice and learning health systems where we use data to drive improvements in the quality of care across the healthcare setting. These are the countries that are involved in the INTRI network. There's over 60 countries now that we're collaborating with. The countries with blue text are ones where we have an INTRI fellow appointed in that country. So Tracy Comans and Len Gray are two of the senior people in Australia that we collaborate with very closely. And in green text are the countries that we don't currently have a fellow appointed, but we're very actively engaged in research with those countries. And you can see that recently we've become very heavily involved in low and middle income nations where health human resources and healthcare budgets are very limited. And we've come up with some creative solutions to deal with the needs of older persons and persons with mental health concerns in those countries. And what's exciting with this international network is you have different cultures, different structures of healthcare system, different population age structures, different models of service delivery. And learning from those differences provides us with natural policy experiments that we can learn from to improve our own health system. Now, it's worth thinking about why we need to think at the system level in healthcare in an integrated manner. And it's a fairly simple answer. It's that people who have comparable needs receive services in different parts of the healthcare system. So that's especially true for people who are older persons, people with mental illness or brain injury or physical disabilities, children or youth who have complex medical conditions or mental health needs, or people who are at the end of life. So not all elderly people live in a nursing home. Not all people with mental health concerns live in psychiatric settings. Not everybody who is at the end of their life is in a hospice setting. In fact, those persons are in contact with all parts of the healthcare system. And so you really need an integrated approach to providing them support. And so there's also many conditions that start early on in the life course, and then you have a lifetime history of having to deal with things like disability or mental illness. From a system point of view, what this means is that we should be thinking about what's the best place for people with different types of needs or different intensities of needs to get services. And from the person's point of view, we need to deal with the challenge that, one person has to tell their story 100 times and may get discontinuous care as they move from one setting to another. And so continuity of care becomes very important for them. And having the healthcare system work in a team-based manner to support the care is more important than a siloed, disaggregated approach to care. Within the INTRI instruments, we have instruments that cover everything from newborns all the way to centenarians. So we have instruments for children and youth, for general adult population, and for older adults getting home care services, nursing home services, palliative care, and primary care services. In Canada, this map shows the implementation of INTRI instruments in my country. Now, we could talk about the Canadian healthcare system, but the Canadian healthcare system is really 13 different systems, and it might even be 14, depending on how you want to count it, because each province and territory is responsible for the management and delivery of health services. The federal government does transfer payments, and the federal government manages some aspects of, armed forces, RCMP, the police service, and federal correction services. But otherwise, these 13 provinces and territories run their own system. So, there's not one Canadian healthcare system, there's actually 14 of them. And so comparability and data standards are very important in my country. And so it's been exciting that most of these provinces and territories, all except for Quebec, have or plan to implement one or more INTRI instruments. And in fact, as of last December, we had over 25 million INTRI assessments completed on over 6 million unique Canadians. So this is the de facto national standard for aged care in Canada. And the data are managed nationally by the Canadian Institute for Health Information. One of the things we can do with that is for nursing homes, we can report at the nursing home level on the quality of care using person level data in 1,500 nursing homes across the country. So from Australia, you can go on to the CIHI or Canadian Institute for Health Information website and look up the name of a nursing home in a city where you know somebody. And you can get information on antipsychotic use, on restraint use, on falls, on worsening of depression, and worsening of functional ability and pain as examples. And it's all based on person-level risk-adjusted data to allow for fair comparisons. That brings us to the advent of artificial intelligence. Up until 2022, I thought, well, analyzing these data is the big challenge, and moving ahead with data standards is important. Now we've entered this brave new world of artificial intelligence that gives us all kinds of new opportunities, but also new challenges in how we think about decision making in the healthcare system. I tend to not want to use the terms data-driven decision-making or evidence-based decision-making because those imply, first, that data speak for themselves. They don't. You need an analytic framework. You need to run analyses of data to answer questions. And very quickly, we learned that decisions in healthcare aren't only based on evidence on one topic where there's exhaustive evidence to say this is the one thing you must do in relation to that one problem. In fact, an evidence-informed approach is better where you're looking at evidence, but you're also taking into account the values of the person providing services, the value framework for society. And so decision making is much more complex because it tends to be a combination of empirically based evidence and then subjective value frameworks that are prevalent in the society. And the question is, how does AI fit into that kind of a framework? If it was a simple matter of if I have X, what is the Y that I should do? In fact, it turns out if you have one condition, there may be multiple solutions for how you respond to that condition, or multiple outcomes that you may need to be concerned about. And we need to think about how AI systems can relate to that. So we have the potential to improve our capacity to make good decisions, but we have to think about what safeguards we put in place for AI in healthcare as well. I tend to think about three different types of artificial intelligence, but these are very blurred categories. There's lots of overlap between these. So on the far left column are predictive analytics. These are all the things that are sort of fancy analytic tools that basically take the quantitative statistical methods that we had in the 1990s and 2000s and now transition to more machine learning, iterative approaches using a variety of different techniques. I'm not so concerned about that because that's where I see real opportunity to make new discovery and make better use of data to answer more sophisticated questions. But there are some interesting challenges in the generative AI category. So with generative AI, we're talking about artificial intelligence systems that generate stuff. That could be text, it could be images or videos or audio files or animations, computer software code, or synthetic data. And there's tremendous potential use for this. So we're all familiar with using chatbots when we go onto an Amazon website or an online service where a chatbot says, "How can I help you?" Those have become much more sophisticated and have some really interesting potential healthcare applications. We can use it to automate, to edit and optimize and translate text or computer code. You can use it to write an organizational strategy. If you need to have a brief written for the minister's office or a policy brief for your board of directors, there's a way to get AI to do that in a pretty competent way. You can use it to create educational content for patients to explain to them in their language and their reading level what is behind a particular health condition that they may be affected by. And you can also use it to take very complex documents and summarize them into a simpler, more straightforward form. So there's huge potential for generative AI, but there's also risk because where there's error or bias introduced, then that information can become problematic. I'm more concerned about new emerging technologies around agentic AI, where you have an autonomous AI system that doesn't have a lot of human oversight that makes independent decisions. It can adapt to change, it can be goal-oriented, it can manage complex tasks, it can learn from experience. But that's one where if humans are out of the decision-making loop, we could very quickly go off the rails where the AI may make decisions that don't match the value preferences of the individuals in question. Now, an interesting question is whether AI can solve problems with bad data. As a starting point, we need to recognize that all data in healthcare are subject to measurement error. Everything has error attached to it. Some has more error than other sources of data. And we can use AI and conventional statistical techniques to adjust for those errors, to deal with problems around measurement calibration or data completeness. We can clean data sets to get rid of problematic observations. And we can, in fact, make inferences from some types of biased data. But what AI cannot do is overcome fundamental problems associated with narrative notes. If all the electronic health record says is had a good day, ate well, slept well, they're not going to be able to make inferences that are meaningful from that kind of stuff. So, really bad data, you can't perform miracles with that. And so good quality standardized data is a foundational building block for any system, and AI can do much better when you have good quality data in that foundation. A really interesting problem that's emerging for us, or challenge, is the emergence of many new types of data. So with new technology, we can now get much more diverse kinds of data for predicting health outcomes, and we have much more massive volumes of data that are coming our way. So, for example, it's imaginable today that a resident in a long-term care home could have a clinical record, including both narrative notes and an inter-eye assessment, combined with sensor data about movement in the home, or they could have a wearable wrist-worn device, for example, for fall detection, combined with genetic data about that person, geospatial data about where the home is and where they came from. And then there's a new type of technology called neurotech that looks at the electric signals of the body to get other inferences about what's going on there. All those data are potentially available today, but there's lots of complexities to deal with that. First of all, as an analyst, I would say it's horrendously complex to think about how I would integrate all those data into one approach to analysis. A very challenging work to do. Some sensor data is better than others, and some may be valid, some may have questionable validity. There's challenges in how you link all these data together because they may all be in one place. If we thought we had privacy concerns 5 years ago, the presence of these kinds of data magnifies privacy issues 100-fold. And some of these measures can be very intrusive. That's one of the really serious concerns about some of the new neurotech measures, where they could in fact infringe on human rights as well. So there's great opportunities with these new forms of data, but there's a lot more complexity that we have to deal with in thinking about it from an ethics point of view and from a pure analytic point of view. One of the things I'm very interested in is when we create decision support systems, is we need to think about whose interests those systems will serve in a healthcare system. And so with any question that comes up in healthcare, we have to recognize that the decisions can vary depending on whose perspective is being taken. And there are lots of competing interests within healthcare. We have to decide whose interests take priority whenever we're making a decision. So in Canada, we're concerned about delayed discharge in acute care. We call that alternate level of care patients because it affects the flow through the hospital system. If you think about a patient who has been declared as having a delayed discharge or is an ALC patient, the patient is interested in getting good care in the hospital, getting better, and going home. The family might be concerned about, well, how am I going to take care of my relative when they go home? And what about my job and then my kids and my volunteer responsibilities I have? The hospital may be concerned about reducing their length of stay because that gets publicly reported. They're worried about the flow of patients through their hospital, and there may be reputational risk or penalties that they face if their length of stay become too problematic. And from the society's point of view, well, we want to minimize tax burden on citizens, and we want to be sure that people have access to hospitals. We could create AI systems to target each of these outcomes separately, but it's very hard to imagine one that does it all. And we have to think about, well, which of these outcomes get favored? Do we focus on the patient outcomes or the societal outcomes? Because we may have different answers for the same situation for the same individual. So I'm going to end with showing you one example of how I've used advanced analytics to create a decision support tool to manage the allocation of home care resources and placement into nursing homes. We created something called the method for assigning priority levels, or the MAPLE algorithm. There's no Canadian bias there, just so you know. Just because it's MAPLE doesn't mean that there's a bias there. What we're trying to do is to prioritize who gets access to home care services or who gets placed into a long-term care home first. So it's not an eligibility or an automated placement system. It's really a prioritization system to say these people have the higher needs. And the way we framed the analysis was on 3 basic outcomes that we modeled. We looked at who was actually placed in a nursing home in real data. We looked at caregiver distress rates because we realized, well, caregivers provide 70% of the care to older persons. And so if caregivers cannot continue, the whole home care system will fall apart. And then we also modeled where people were rated as being better off elsewhere than a different place than the place where they're living today. So we modeled 3 different outcomes for this. And this was our original MAPLE algorithm. It looked at physical disability, behavior disturbance, cognition, falls, wandering, nutritional issues, and issues around medication management, pressure injuries, and their environmental home. And we could classify people into 5 different priority groups. So somebody with disability and behavioral issues, or disability combined with cognitive impairment and falls would be a very high priority for more home care services or admission to long-term care if that was the appropriate target for them. When we did the original research was just as we were starting to pilot test Interi systems. So we had 4,800 clients in 14 different home care regions. Then we had validation samples from different provinces and different countries to create that decision tree that I just showed you. We're now updating the MAPLE algorithm, and now we have 4.4 million Interi assessments in Canada. We have data from many other countries, and we have a longer time period to work with. So that tree that we had before is now elaborated into this much more complicated tree that takes into account many more variables and divides people into 7 different groups of resource intensity. If we look at those 7 groups, it's very strongly related to caregiver distress. So you can see in group number 1, 10% have distressed caregivers, whereas in group number 7, almost 80% have distressed caregivers. If we look at being rated as better off elsewhere, in group 1, it's around 10%. In group 7, it's half of that population. And if we look at 90-day admissions to nursing homes, you go from below 1% in group 1 to around 15% within the next 90 days in the highest group. So this new algorithm is a bit more granular, and it's very strongly related to the outcomes of interest. But here's what happened in our healthcare system over time. We started using the old MAPLE algorithm in 2005. And what you can see in the light green bar at the bottom, when we started, around 25% of home care clients were in that lowest, lightest care population, and less than 5% were in the dark purple, which that category didn't exist. So we were serving a fairly light care population. Almost 40% were the bottom 2 categories. After almost 20 years of using the system to prioritize who gets access to home care services, the dark green group went from 25% to below 5%, and the dark purple group went from below 5% to now 25%. So we've shifted the home care population to serve a much more complex population than we used to serve. Some of those lighter care clients are now served in other less intensive care settings, but home care itself has become much more focused on the most complex patients. That's a good thing because you'd want your system to focus on persons with highest needs. But the unexpected consequence is the effect on caregivers. So this is from a CAI report on caregiver distress. In my province, we now have over 40% of home care clients have distressed caregivers. In the Yukon Territories in the far northwest, that's 47%. But in some provinces like Alberta, it's only 15%. So within our country, we have tremendous variation in caregiver distress rates. And now we need to look at what's underlying that. And we can risk adjust those caregiver distress rates using that MAPLE algorithm. So that's it. It's a bit of a whirlwind tour, but Janine, happy to stop the screen sharing and have a chat.
That sounds great. And how fascinating. Really, really interesting to see how those MAPLE scores can so accurately demonstrate how data changes real world approaches, decisions, and outcomes for people. So yeah, really fascinating. And always those unintended consequences are interesting to unpick as well, aren't they? So you talked quite a bit about the integration of the care sector in Canada. Can you give us a bit of an overview of Canada's efforts to improve integrated care?
Yeah, so when we started all this, we really had different silos of the healthcare system. So most sectors of the healthcare system had little or no data, and there were no data standards there. So what having data standards introduced across different sectors is allowing us to do is to have more comparable information about people across settings, so we can ask better questions about who gets care in what settings. And we can share information between home care and nursing homes so that as people go from home care to a nursing home setting, their information can follow them and you can have that longitudinal view. But because we went from a fragmented system to start with, we're in the process of making it better integrated. If I look at the Belgian approach to what they're doing, they have started right from the beginning with one common portal where all Interi data sit, and everybody sees those data at the same time. So if I'm in a nursing home, I can see assessments that were done in home care or in palliative care or in acute care at the same time. Whereas in the Canadian context, because we implemented these separately over time, we're still in that process of, trying to get all the kids in the playground to share, to share data from one sector to another. But it's becoming more integrated. We have something called Ontario Health Teams, which are intended to be integrated teams linking all the sectors together. But they're still dealing with some fragmentation of data systems. We have inter-eye systems in place in home care, in nursing homes, in palliative care, and mental health services. But acute hospitals themselves don't use inter-eye assessments yet. Home care will do assessments of acute hospital patients, but they use those data for home care purposes. So we're still on a journey trying to make things more integrated.
Yeah, it's a complex problem to solve for, I know. In terms of your integrated care approach in Canada, what are some of the key lessons that you've learned? And I suppose adversely, I'm interested in hearing a little bit more about those really big challenges.
Yeah, so having comparable data is the first thing you need to change the system. So usually when you turn the lights on, the first time you see data, you get surprised by things you didn't expect to see. So one of the very common things that we saw in the nursing home sector was very high rates of physical restraint use until people saw the data and started to drive that down. Similar kind of thing around antipsychotic use. We also saw lots of people that were placed prematurely in nursing homes and people in home care settings who had fairly light care needs. So that evidence we use to try to target things to people who had more complex needs that were taking that were not being served as well and took longer time to get them services. What we didn't do as well was to think about the people that were getting those services that still had needs. So having low needs doesn't mean you have no needs. So some of those people we took off service, but they still had needs, and we didn't adjust the reimbursement levels to the sectors now dealing with a much more complex population. So you saw home care today is much more complex than it was 20 years ago, but the home care budget change hasn't really matched that. And so what's happened is more burden has gone on to families. And it's maybe it's an unintended consequence, or it's a consequence that nobody thought of because we weren't asking the question in the first place. One of the other things that's interesting is because we started with siloed healthcare systems that we're now trying to integrate, there's a challenge with getting people to share data. Sometimes data become a source of power. So if I have data, well, why should I share it with you? And so getting people to understand the data are really about the person, and it's the person's right to have everybody in their circle of care have the information that's needed about them to provide them good care. The data don't belong to the provider. The other thing is that we don't do a very good job yet of sharing information with patients and their family. So we very quickly go to privacy barriers to say, oh, well, I have to be careful about privacy concerns. Well, if they're my data, why is there a privacy concern for me accessing my data? There's a tendency, though, to want to keep this stuff secret. And when we do share information, it's often not done in a way that is accessible, sometimes too technical. If you've looked at a laboratory result for blood work, at least you get information, say, what's an out of range value? And you can Google it to see, what does it mean when I have high hemoglobin or whatever. We don't really have those systems in place, and clinicians aren't used to talking with nursing home residents about their assessment results because they didn't have to in the past. So that's a culture change that has to happen for sure. And then it's a matter of getting everybody used to understanding the language. So one of the most difficult groups to deal with are geriatricians who went to university and were taught the mini mental state exam, the geriatric depression scale, and the Bartel ADL scale. They learned that 20 years ago, and they don't want to learn anything new. They still want to have those things, but those aren't part of this integrated system. So there's an educational challenge that you have to deal with to get everybody used to understanding the comparable measures as well.
In Australia, government-led digital transformation has brought significant change to aged care organisations. I'm interested to seek your thoughts on what opportunities this might create. So when we're modernising digitally, we're having access to enhanced data, sharing big data analytics, data standards, artificial intelligence. What sorts of opportunities should we be thinking about as we're on this digital transformation journey?
For me, the biggest opportunity is around quality of care and resident experience. So I like to frame any decision-making system in terms of the Institute for Healthcare Improvement, the IHI quintupling framework of, can I improve outcomes of care? Can I improve the experience of care, the work life in there? Can I improve equity, and can I improve cost effectiveness? And so I think we can use better data to evaluate the extent to which we're making progress in those areas, and we can do more sophisticated analytics to ensure that we understand the underlying mechanisms that can cause variations in quality and yield better health outcomes. I think when we have better data systems in place, we can understand complicated populations better and more effectively respond to their needs. And that's really the future of healthcare. Every country around the world has limited budgets. We can't, spend unending amounts of money on healthcare, and so we're trying to do the best we can with, limited resources, whatever the limit is set by the country. And so when you have these more complex populations that you're serving, you have less room for error, and so you really have to get it right in terms of what services are being provided. And you need these more advanced data systems and good quality data to get there. My example with Maple shows that if you don't pay attention, you're going to run into real trouble with caregivers who could end up in hospital themselves.
Yeah, I was really interested, John, in your presentation talking about it's not just about the data, you have to think about the principles, the outcomes you're actually looking to achieve. And it makes me think about the value proposition and the role of ethics in working with data. How did that play into your development of Maple?
Well, so what we did with Maple is we talked to different stakeholder groups to say what's important about home care, and part of it was understanding the role of home care in the overall healthcare system, and also understanding who actually provides care in that settings, and trying to get at what are the things that make home care work and what are the potential failure points. And I think by concentrating on caregiver outcomes, we've also started to make the point that home care isn't really about a dyad of the service provider and the patient. You also have to take the family into account because the family's got to be part of the unit of intervention. In New Zealand, there was a Maori health review done last year, and they actually expanded that argument further to say that the entire fauna, the community around the person has to be considered. So you have to think about the individual and the support networks that they're embedded in order to provide them support. Because if 3/4 or 70% of the care comes from them, you got to be sure that the caregivers have the capacity to do what they need to do, so you don't have to spend that money. And so if I look at home care expenditures in Canada, it's, $150 a week is about what a home care client gets. That's less than 1 day of stay in a nursing home. And so there's a sector that things are really inexpensive, but it's because 70% of the labor cost comes from family. And so you've got to do things that really understand what drives caregiver distress, but you also then have to respond to caregiver distress.
Mm. Yeah, really good point. Bit of a change of tack. So you talked a bit about the data standards across international jurisdictions and how that's allowed comparisons to be made across countries that give us some really interesting insights. It was particularly interesting to see the reach of Interact and how well represented you are across the world. Could you talk about some of the benefits we've seen from the standardization that's been driven in Interact?
Yeah, the opportunity with cross-national data standards is that you get to learn things about yourself that you didn't know. So if all you do is look at yourself in the mirror, you become kind of used to it and think, okay, well that's the way things are. But when you see other experiences, you can learn from that to evaluate your own performance. So For me, the most important example was early on in my career looking at physical restraint use. So this was the mid-1990s. I did my first study with inter-eye systems in Canada in Toronto post-acute hospitals. They were called complex continuing care hospitals, which basically took a medically unstable nursing home resident population. And we did a study with inter-eye measures, and the accreditation surveyors in my hospital said your rates of physical restraint use were too high. So I looked at my hospital's data and I looked at other hospitals in the Toronto area, and I found the rates were all the same. So I presented those to our surveyors and said, here's our rate. It's 40%, and that's what everybody else's rate is. And they said, well, you don't want to just do what everybody else does. You want to get better than everybody else. So just having normal performance isn't good enough. I was invited to join Inter-Eye that summer, and I went to my first meeting where they were working on a special issue of age and aging, and they showed data on restraint use in 4 or 5 other countries. Remember, my rate in Toronto was 40%. The rate in Nordic countries was below 10%, and the rate in the United States was 15%, 15%. So all these other countries had much lower rates of restraint use than Canada does. And Canadians really get annoyed when the healthcare system in the US looks better than the Canadian system. So it started a whole dialogue, and it helped to inform a political discussion to say, we can't continue on with this. We have to change this. The national rate now is below 5%. So we went from 40% to 5%. But when I first saw the data, I thought, what's wrong with 40%? Everybody's got the same rate. And it's only by looking at other countries we realized that we were an outlier. The flip side of this is the Canadian guilt complex with Nordic countries. So we think we're nice people, but we always think we're not quite as nice as Swedes and Norwegians and Danes and Icelandic folks and Finns. And so we often will have studies or news reports to say we need to provide the same kind of home care services that they do in those jurisdictions. And, because in Denmark, apparently you can get 6 home care visits a day to keep you in home. Well, when we look at the data from Nordic countries using the MAPLE algorithm, we realize they serve a much lighter care population than we do. Our comparator is more like the Netherlands and the UK and New Zealand. But in Italy and France, they serve a much heavier population. So there's no point in feeling guilty comparing ourselves to the Nordic countries because they're not serving the same population we are. We can ask the question from a policy framework, should we target that light care population? But they're not our peer group. Their peer group should be the UK and the Netherlands.
I like the idea of us getting competitive about healthcare outcomes, just not only soccer and the football and cricket. Yeah, that's great. You mentioned some compelling applications of Inter-Eye across Canada. In Australia, we have been working across government on a program called SPART, which is Advancing National Healthcare Data Exchange, and it uses the FHIR standard to do that. Given the diversity of standards globally, so there's FHIR, there's Inter-Eye, there's many others, how would you approach integrating healthcare data across countries, and what sorts of challenges and opportunities should we be thinking about?
Yeah, so the Canadian Institute for Health Information has done a great deal of work of applying FHIR and HL7 standards to Inter-Eye data to allow for that interoperability within the electronic medical record. And so that can definitely be done. What Inter-Eye has done is to take things a bit further. So, diagnostic codes, the diagnosis is diagnosis to some extent. And so having the comparable code about how a diagnosis is handled in a computer system makes sense. But we create standards around things like how you measure pain or how you measure depression or a pressure injury that's consistent across settings and across countries. So the clinical definitions of the concepts that we're looking at is more detailed and more standardized than what you would have with just FHIR and HL7 alone. So, a challenge would be if you were to measure physical disability in terms of, can the person lift themselves independently off of a chair to a standing position? versus does the person. A granular measure of, how much help they need is different from do they do it yes or no on a tick box. So we have data standards that are very fully elaborated in defining what we're talking about. We apply observational time periods. We do a lot of work to ensure we get good reliability and validity with it. So we can use the FHIR standards for sharing the data, but the what we call the I-code standards, is a conventional, a naming convention that we use for the items, so that if we measure pain, we measure it the same way across 13 different kinds of care settings, rather than trying to map it from very disparate settings to say, well, this is probably about the same.
Yeah, you spoke a bit about the quality of data and that presenting a challenge, but also not being a showstopper in terms of extracting some value from the data. I was wondering if there are, or is there an intent to sort of set standards around data quality where we might grade the value and the quality of sets of data?
Yeah, we do a great deal of work with an INTRI around reliability and validity of the data systems in the first place. So we do lots of international testing to see if two people independently do the same assessment, do they come up with the same answer? And we can do that in research studies, and we can show that, yes, we get good inter-rater reliability, which is important because you want one clinician to believe that another clinician would get the same answer as they would. We also do lots of validity testing to look at, are you really measuring what you think you're measuring by looking at predicting outcomes or looking at gold standard measures. But the challenge is it's not good enough just to have good research data from a research study done once and then 10 years later nobody's replicated the study. You really want to think about data quality from the real-time use of data, the real world data. And so we have statistical tools that we use to evaluate data quality. And that's very helpful as we go into new settings. So an important challenge that we had was, as we went from the post-acute hospital settings originally into nursing homes, the hospital folks said, well, I'm not sure I can trust a nurse in a nursing home to do the same assessment. And we showed you get the same data structure, same reliability, same validity from the two. In home care, we have clinically based home care services that were usually nurses and social workers are the case managers for that. But we also have some community support services where it may not be a regulated health professional doing the INTRI assessment. We again use these statistical techniques to show they get the same answers, that they're basically fully interoperable in terms of the data quality that are there. We can also use those tools, though, to detect problems that emerge in data, either because of poor coding practices or because of gaming. So right now, a concern that we have is we're publicly reporting on antipsychotic use, and we set a national standard to drive that down from 23% to 15% as the national rate for potentially inappropriate antipsychotic use. But what we see is there's some homes that are trying to get there by changing their coding practices around exclusion criteria. But I've got 20 years of data, and I can say, okay, in this home, for some reason, we have for 19 years, a rate of 5% of the residents have delusions, and suddenly it's gone up, but none of the other things have changed. So having these data tools lets you do sophisticated analytics that can also protect the integrity of the data system. But there's also a cultural dimension. Everybody has to value the data system and want to protect it, because if we allow gaming to happen, then we potentially go back to my PhD supervisor's book and we have no data.
It's impressive to see the scientific method at work there. You spoke about, having the idea, having the methodology, and then testing, and it is that continuous loop, isn't it, that iterates towards better quality. Very last question. You did mention that your professor, William Forbes, started building the data before the computers were readily available to utilize it. What should we be doing now, in your opinion, to prepare ourselves for that next technology horizon?
Well, you've got a great advantage over a country like Canada because you can benefit from the 25 or 30 years of experience that INTRI's had of going into this stuff. So in many ways, you can leapfrog ahead of a country like Canada, because we're now in the middle of converting people from the old enterprise standards to the newer standards. So you can, in fact, accelerate your adoption with it. The most important thing to work on with this change is the sharing of information and the public use of the information to inform quality and policy, but also working with clinicians that they embed the use of the instruments in clinical practice and share it with patients and their family as part of routine practice. Because the closer that the use of the data comes to the clinical decision that happens at the forefront, the better the data quality will be. Because now it's me as a nurse working with you and your family to try to provide the best care I can for you, not about, okay, how can I code what's, your characteristics are so I can get $5 more for my nursing home. Make it more about patients and their family, and you'll get better data quality out of it.
Professor John Hirdes, it's been wonderful chatting with you. Thank you so much for giving up your evening to talk with us. We've really appreciated your insights and experiences, and we hope to talk to you again in the future.
Great. Thank you for having me. It's been a pleasure.